Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, everyone. Thank you for joining the clinician webinar today. I am Shannon True Bailey. I'm a nurse here at Axxess and part of the product team. And today I'm going to talk to you about the OASIS D1 and the plan of care profile in Axxess software. Okay, so we're going to a testing agency, so this is not real data, so that I can show you how the software works. Okay, so we're going to go into an OASIS D1 start of care. First, you'll notice that we have the section menu to the left, and this helps you navigate from section to section the way you assess a patient. So you're going in your order and you're not required to go in any specific order. So I really appreciated that. Before I was even at Axxess, I appreciated that that one feature of the software, because I knew where I was at all times and I could navigate the way I wanted to in the order that I really did assess the patient. Okay, second of all, I want you to notice that we have color coding in the Axxess software. So those questions or sections that are outlined in blue are your assessment questions. So this is your physical assessment that you obtain or document from your visit. Okay, and then we have a green section. These are all the M questions or OASIS questions required by Medicare to give them the data that they collect to manage their payment of home care, to look at the quality data and those things that occur in home care, and it helps them make decisions for future changes. Okay, and then you have a purple section. That's the plan of care profile. This is the workbench where you build your plan of care for that episode. Let me go to one other section and show you the gray. So we have blue, green, purple, and gray sections. The gray sections populate the plan of care, what we used to call locator boxes. It's those items that the conditions of participation require that we put on our plans of care. So when you answer these questions, this information flows to your plan of care that is automatically generated when you finish your OASIS. Okay, so let's just start from the top and go through each section. Each section has something specific that you need to know and something special. So we at Axxess have a concept of one source of truth, and one of our sources of truth is the patient information. This information is entered at intake. The intake coordinator will populate will open and start a chart on this patient, and will enter all of the OASIS data, even diagnoses and source and timing. All that will populate your OASIS. And what you need to do as an assessing clinician is just verify that all that's true. If you find an item in this section that needs to be edited or corrected, then you go to that one source of truth by using this Edit Patient Info button. That will take you to this section in the software. You can edit it here and then save, and it will take you right back to your OASIS. So one source of truth you'll see, and I'll mention throughout the software. There are several things we have that follow that concept. Okay? And then let's move on down. You'll notice that this is grayed out. This is entered at intake and is not editable unless you go back to this intake button, and that goes for all of these grayed out sections that were populated at intake. But if you need to edit those, it's possible to do that. Let's talk about the New 90 date. The MOO 90 date is your date the assessment is completed, just like it says, and that means you have completely gathered all the information that you need to build a plan of care for this patient. That is not the date that you document your assessment or you finish documenting your assessment. It's the date that you finish gathering information, and Medicare gives us 5 days to do that. Sometimes it takes a couple of days to get more information back from the physician, or you need to speak with a family member that can give you more history on that patient. Sometimes it takes a couple of days. So the MOO 90 date is the date you finish gathering your information or you finish assessing that patient, not your documentation completion. And then the, let's go down, episode and timing. Remember that in PDGM, the episode timing, early or late, is now different than it was before January 1st under PPS. So under PDGM, your early is your first 30-day billing period in your 60-day episode. So you still have a 60-day episode just like before, but now under PDGM you have 2 30-day billing periods. So you'll have 30 days. The first 30 days are considered early. Anything after that is considered late, which is vastly different than it was under PPS. So very big distinction. First 30 days is early. After the second 30 days and on for the whole continuum of care is late. The source of that, I'm just going to talk about that now because episode, source, and timing are one of the components to build your home health resource group for under PDGM. So the source is institutional or community. So institutional is when they are referred from a hospital. So an institutional early would be a patient that you received from a hospital and this is their first episode. Institutional late is a patient that may have gone to the hospital during that episode. If they have been in the hospital in the 14 days preceding the second 30-day billing period, that will be an institutional late episode. An institutional pays you more than community, so if you need to capture that to have the accurate reimbursement that you're owed for that care. So a little bit of PDGM. Let's move on. I want to show you the diagnosis section. Let's just start at the top and start with the vital sign section. So our vital sign section is this one component that you'll see. It is the same that is in the nursing note so that it's very consistent and will give you opportunities to document more than before. So you'll have your left and right, lying, sitting, standing, blood pressure that makes it easy, your temperature, and all the routes that we potentially use, etc. The rest is pretty much the same, although you can expand your pulses. You know, sometimes we check pulses all around. I have always done an apical and radial pulse, and I usually document those. Lying, sitting, standing on both of those options. So I've never seen a software have this much opportunity to accurately document. So I really appreciate the being able to expand the pulses and the blood pressure for that matter. I also want you to see that we have this little checkbox that will protect you if you are unable to collect a vital sign. For some reason you're not able to collect the blood pressure because well, I'm not even going to venture to have a reason why you couldn't do that, or a weight for a CHF patient. This protects you and from surveyors looking and saying, why didn't you gather this information? Because this will cue you that you need to document why you weren't able to document that, why you weren't able to assess that. In your narrative you can explain. Okay, and then we have additional measurements. So we add the blood glucose here, the random and the fasting. This causes some confusion for some people because in history and on most software, excuse me, we document that in the endocrine section. But because all of this information changes every visit and we want to log this information, we put it all in one section so that you can document your glucose, your abdominal girth, if you're measuring that, your ankle and calf circumference, and your PT-INR. I mean, we have so many patients that we check weekly or even more frequently, the PT-INR, and we need to log that. We need to see a log, and all that goes into the vital sign log that's easily printed for your physician. Okay, so that's the vital sign section. Let's go to the diagnosis section. This is full of cool features. So first of all, we have the search feature where you can search by number or by text the diagnosis that you're looking for. So it'll give you a whole section of diagnoses, and you can just drill down from there. And when you get to the most specific that you can get to with that diagnosis or the one that you're looking for, it'll populate. So diagnoses that are not Z codes will have a severity, and we still need to document the severity of this diagnosis. If it's a Z code, then you will not have the severity. Let me see if I can show you how. For certain codes, you don't have to have a severity. So there's a Z code. I'm going to choose that. The severity rating goes away so that you're not dinged for that. We also give you tooltips, and this is the guidance straight from the OASIS guidance manual. So this tells you what the intention of the item is, what the responses that are offered mean, and we give you the data sources. This is these are the acceptable ways you can gather this data that CMS accepts, and gives you a cue on how to collect that information. Okay, and then you'll notice that we have a little book icon. This is for teaching. Straight from your visit note, you can connect to Medline Plus. These are teaching sheets on those diagnoses and helps you fulfill that commitment to teach the patient about their disease process. And you'll notice that it is translated as needed into Spanish. Okay, let's go back. So another cool feature about our diagnosis section is that you can list all your diagnoses and you can resequence them, or QA can resequence them according to the need of the patient and the primary reason that you are having them on service. After you assess fully and you think about this and you go through the documentation, you may realize that COPD is really your primary reason, and that's what the doctor explained to you, is that they're going to be admitted for this care. You kind of were tempted to use the diabetes, but the physician said this one, so you can resequence as it becomes necessary. Okay, and then you can add up to 24 additional diagnoses. That's what CMS accepts. So you can just keep on adding up. If you realize that you don't really need to add that many diagnoses and you're not going to address those at all, or they won't impact your care, then you can take them away. Very easy. Okay, let's move on. I mentioned single source of truth. Allergy section is also what you add to the allergy profile, which populates everywhere that it is required, for instance, your medication profile. Okay, and then the plan of care vital sign parameters. I love how this is laid out. It's very simple, easy to see, and moves in a way that makes sense. Okay, and these are all the parameters that your agency or the physician has for their patients. So usually your agency will have a set of vital sign parameters that they will want you to add here, but there are some patients who you need to have stricter parameters on. So these are always editable, and you can make those patient specific. Immunization log, another area of one source of truth. I won't go into detail about that because it follows the same. You enter the immunizations, it goes into their immunization profile that populates where that is necessary in the software. Okay, so we do have some risk screenings, and you can see here, let me just take a side note. You can see here that this was already populated, actually, from what we put in the vital signs section. Okay, and then we'll go into the, in each assessment section, you'll have the opportunity to enter orders for discipline and treatment. This is your plan of care profile. This is what is the workbench and builds your plan of care order for that episode. So we cue you when you are in the risk assessment section, we give you the opportunity to add the intervention for that issue. So if the patient was found to be at high risk potential for hospitalization or for infection, then you would choose that problem statement and add the intervention and the goal for that. I'm going to add them later. On the nurse's note. Okay, so that is the plan of care profile that I will go into more depth later. I want to get through the OASIS first. Okay, then the advanced care plan. We are required by CMS to address the advanced care plan on every patient for every episode. So they're not required to have advanced care plan, of course, but we're required to talk to them about it. So we give you this section that is also one source of truth. You can come in here and document if they have or they don't have an advanced care plan. Okay, and then let's check DNR because I'll show you something about that later. Living will, durable power of attorney, you'll get to say who that is, and that populates everywhere in the software that it needs to go. So let's, when you save and exit, you go right back from the care plan to the OASIS. Okay, and you'll notice that that's a green, you have a check mark and a nice pretty green box. That means that you did do that. So that's just a little confirmation or affirmation that you completed that task. Okay, let's move on. We talked about the gray sections. We'll move on from there. Let me see. Let's go to the pain section. Now you'll notice that we also have a concept of avoiding cognitive overload. So what we do is we give you the streamlined, uncluttered view. And if you need to drill down from there, if this patient does not have pain, we don't need to look at all the pain documentation options. We just need to say, no, they don't have pain. And then we always give you the comment box to talk about that if you need to. So what if the patient does have pain? Then we have the opportunity to document all of the pain details. And look how much this is. Okay, so all of the pain is documented here. And you could see the difference in the cognitive overload of this. We don't want to overload you unless you really have to document that. Okay, so that's avoiding cognitive overload by giving you that streamlined view at first, and that goes into our nurse's notes as well, which I hope that you will join that webinar at another time to see the nurse's notes specifically. Okay, let's move on to the integumentary status. Okay, so we give you the Braden scale and, of course, all of the M questions. And then we give you the wound manager. So right now we have this wound profile, the wound care flow sheet. It gives you the opportunity to document all of the necessary details about that wound. Okay, we also give you the opportunity to choose and upload a picture of that wound. And then so all of these details will stay, and you'll see the load previous here in a few minutes. I will show you that. The wound documentation loads. So you know how tedious it is to document a wound. We save that information for you, and you can change what needs to change, such as the measurements or the surrounding tissue. And then the treatment performed in the narrative will also be captured, so that if the treatment is the same, you don't need to change that, and you could just document in the narrative anything that has changed for that wound. So that is the wound manager that is available in the integumentary status, in the integumentary section. Okay, and then let's move on through. I want to show you, I need to show you this. So when you load previous, there are things that are not going to be copied over to your new note, which are things that absolutely change every time, and that are your vital signs, your last bowel movement, for example. And then in your assessment sections, you'll notice in avoiding cognitive overload, we give you the streamlined view, and then when you need to drill down on any assessment finding, you will be able to drill down as needed. So you'll notice that, you know what, this patient had abnormal bowel sounds. You see the colon here and the colon here? All those indicate that you have more documentation to this assessment finding. So you'll say that this patient had hypoactive bowel sounds. Then you'll get to document where they were hypoactive. So drill down as necessary to avoid cognitive overload. I love, love, love that. And then, of course, in every assessment section, we give you a comment box so that if you have something very unusual for this patient for this assessment section that is not found in the standard assessment, you always have a comment box to use. I use the comment boxes to discuss history of disease processes or history of that section or that system. Okay, so you'll also notice that this is grayed out, and that is part of our validations. Our validations compare your assessment findings with your OASIS data, so that will not let you document something that is inconsistent with each other. So we said that the patient is incontinent here, and up here we are not going to be able to say that they have a suprapubic catheter, urostomy, or indwelling Foley catheter, because that is not consistent with being incontinent. Okay, so we didn't say, if we were to say up here that the patient has a Foley catheter, oh, I don't want to do that. No, let's do that. Patient has a Foley catheter. It was put in on January 1st, and we are managing that Foley. Then down here under the M questions, we cannot, that is not really working right now. Did I undo that? We cannot say that the patient is incontinent. The only thing we can say is that the patient requires a urinary catheter, because we already documented that up there. And it flows both ways. If you answered your M question first, it would gray out the ones that you would not be able to document. Okay? And the same with the ostomy, the GI section. The same for all of the M questions compared to the assessment sections. So you'll see that when they're grayed out, you cannot answer them, and that's because it's inconsistent with your assessment or vice versa. Okay, let's move on. I want you to see the changes in the D1. You know, in the D1 assessment, the D1 OASIS, CMS stopped requiring answers to some of the OASIS questions. I will show you that in a little bit because I need to get into a follow-up OASIS to show you those. I apologize. They are not in the starter care. Okay, so let's keep moving on because I'd like to keep you to a time limit. Let's look at the functional abilities and goals. We have managed the functional abilities and goals differently than anyone, and I absolutely love this feature. So there are a lot of questions in these GG sections, and what we have done is given you the apply to all feature. So when you're assessing this patient, you can answer their normal, what they probably are for every section. So let's look at prior functioning. So before this patient had this current illness or exacerbation or injury, they were independent. And they were independent with self-care, indoor mobility, stairs, and functional cognition. So you're going to answer this question right here, and then you're going to apply to all. And it is going to populate every question beneath it. Look at the time saver on that. So that is also for the GG 130 and 170 questions. You have your starter care assessment, and then you have your discharge goal, what you would like for them to be at discharge. So you can say that right now they are dependent. And you can apply that to all of these sections. Now, say they are dependent for their toileting, their showering, their upper body dressing, but they can feed themselves. They can sit there and feed themselves. You can change the answers individually. Okay? So I love that. That saves me so much time whenever I'm doing an OASIS, and I love it. So you can also do that for your discharge goal. Populate every question. Okay, now look at mobility down here. You do still have the option to say that this patient is not attempted due to medical conditions. Remember, CMS says that you have to answer, for sure have to answer at least one assessment and one discharge goal on these sections. We make it easy to answer all of them, so I really love that. Okay, let's go to the endocrine question, the endocrine section. So if the patient has diabetes, I want you to look at this because this has caused some confusion for some people. I want you to look at the blood sugar range, fasting and random, but same concept. This is the range of blood sugars that your patient has experienced over the last week or month or 3 days or 1 day. Whatever time parameters you want to use, you can look at their meter, look at their written log, go by what the physician said. However you want to document this, this is not the value that you get on the day of assessment. That blood sugar result goes up into the vital signs section. So this is really the range. This will give you the cue to look at that. And when you look at a range and the patient's fasting blood sugar range is 300 to 380 over the last week, you know that changes need to be made. And when we are prompted to look at that range, that spurs us to call the physician and address that issue. If we're not looking at the range, if we're not cued to look at the range, we may miss something that is really important to the care of that patient. So remember that this is not your current reading. This is the range over the last episode or period of time. So very important. Okay, so that's the most important thing to know in the endocrine section. Now let's just go through and look at the screenings. We're just going to run through here, and then we're going to talk about the plan of care profile. So I want you to see the medication profile. Our medication profile is really fantastic. You'll notice that when you open the medication profile, it's easy to see who this is. You'll see the allergies, the diagnoses, the pharmacy is here. You'll also have the opportunity to add a medication, and let's go ahead and do that. Now we have long-standing. That means you don't really know when it started, or the patient has been on it for a really long period of time. You don't necessarily have a recent start date. You can use long-standing, and or if you know that the patient has started this medication, just in the hospital when they just started it in their just prior hospitalization, you'll have the start date. If it's an antibiotic, you can have the start and DC date. So that means that will fall off of your current medication profile on the DC date. So I love that. Okay, so let's look here. You can search for a medication, and you want to use the search option for the medication so that you'll have other features that go along with it. So let's look at vancomycin. We'll search for that medicine, and we're going to have 1 gram in 150 mils IV. Okay, so and that was from Dr. Brown, Charlie Brown. And you'll notice that when you use the search, it gives you the classification of the drug. So if you don't use that search, you won't have the classification, and then you will not have an accurate drug interaction profile. So it's really important for you to search for the medication. Now there are some medications that you don't have the right dose for. So let me see did we have that on vancomycin? So if you have a different dose that is in this formulary right here, or the list, then you can choose one that doesn't have a dose, and you can document the I needed that. You can document your specific dose, and it'll still give you the medication classification. So always look for that. Always use the medication from the list. Okay, and then of course you can document the frequency. The route also gives you a drop down, and then you'll say whether it's new, changed, or unchanged. This is a new medication for this patient. It just started today, and we're going to do it for 7 days. Okay? You'll notice down here also that you could say, click here if a new medication is found in the home and no order is required, or click here to create an order once the profile is signed. So that will automatically pop up an order form with your medication profile, your medication dropped in on the order. Okay, and then you're going to save and exit, and you'll see that that lands on your medication profile. And then anytime you change your medication profile, you add a medication or change a medication, you need to do a drug interaction report. You can choose 2 medications to choose and to compare, or you can check all of them and compare all medications with each other. So you could check interactions and then get this beautiful printout of the drug interactions. I love this drug interactions report more than any other in the industry. It is very complete. It's so helpful for me as a clinician and for the physician that I send it to. So you'll notice that it gives you the 2 drugs that are interacting, and we have it in order of severity. So you have all the major drug interactions at the top. And then you'll have some guidance for you as a clinician and the physician. It'll tell you what the interaction is, what kind of problems it can cause, and what is the good management strategy of this. And then it'll also give you teaching tips to talk to your patients. Talk to your doctor before using ibuprofen and warfarin because of this interaction. So I love, love, love our drug interaction report. Best in the industry. Easy to print and send. And it's very clear what the issues are. And then, so let's go back after we have printed the drug interaction report, because it had some major drug interactions. I need to call the physician and I need to send a copy of that to him. After I've gotten that, I can sign the medication profile. Remember that you always have to sign the medication profile when you change it. Okay, so I want you to see this. This says medications have been added that requires a physician order. Click here to create an order. So I'm like, oh yeah, I just got that today. It didn't come with the face-to-face. I just got that verbal order today. So it'll open up this order form for you to complete and send off because you got that verbal order today. So on another day, we will go through the physician's order. And it is pretty fabulous as well, but I just wanted you to see that that will drop into the physician order. You don't have to retype it or anything else. All those that were added need a physician order and dropped here. So we're not going to do the physician order now, but you have checked your drug interactions and signed your medication profile, and the medication profile is the one source of truth. So if you go in to the medication profile from your OASIS, from your chart, from an order form, it all goes to the same medication profile. There's no duplicates. This medication profile populates every area of the software. Okay? And then you have a medication administration record, so just easy to document if you have, given any medication IV or whatever during that assessment or that OASIS visit. And then let's move on. I'm just going to click through some of these. Let's look at therapy need. You need to put in your number of therapy visits in this format, and this is the same with, this is what Medicare requires, so that it should be the same with any software, but you will use a 3-digit format for that. So, and then your supply manager, that's another source of truth that you can use to manage your supplies. I want you to see that in the OASIS we have the aid care plan, and so this is an opportunity, when you're assessing your patient, if they need a home health aid, and so you can add that aid care plan right here from your OASIS. It doesn't have to be scheduled separately. And this aid care plan I have completed prior, so you can see how it looks. Can be used for personal assistant services, homemaker, or other if you happen to provide those services from your agency as well. Services in the home, things to report. So these are cues to the aid. Also, we always give you plenty of text area to specify information that the aid will need to know specifically about this patient. And then down here, when you document what the aid or you order the task that the aid needs to complete, whatever you check will show on their plan of care. They will not have anything on their plan of care that you did not ask them to do. Okay, so if they are not going to be weighed and you don't expect for them to be weighed, or you're not going to have them do any vital signs, then that will not show up on their care plan to do. So and as always, we give you plenty of area to add instruction or comments or text. Okay, so only the things that are required for the aid to do will show up on their care plan, and you can see that this is such an easy check, 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 add a comment if you want to. Plan of care takes just a few minutes and is very complete and thorough. And then you'll sign that. Okay, so on the summary of care tab, this tab is very involved, and this is takes a little bit of thinking and time, but we have made it very easy. So your face-to-face information, your last physician date, very important for you. The number one reason why episodes get denied or rejected is because of the failing to complete the face-to-face in a timely manner or get the face-to-face in the first place. You have to have face-to-face information, and that is just documentation from the physician or the hospitalist that says why we need home care in the first place. It talks about home care and has the orders and the history of the patient. So you have to have that face-to-face information. The patient has to see a physician within the last 90 days or by 30 days after start of care. Okay, face-to-face is a big headache, but is absolutely necessary, and you need that information anyway, so follow up with the face-to-face. Okay, the infection log, we give you the opportunity to add an infection log from your OASIS. Also, again, very easy, everything that you need to do. But one really cool thing about our infection log is that we give you the list of CDC reportable diseases. This is just a cue to let you know that if your patient has one of these reportable diseases, you've got to report to the CDC. So, and then, of course, we give you plenty of text. And then what we do is we give you the follow-up section. So you will keep this in the patient's chart in the schedule center and be able to go back in it after the patient has completed their antibiotics that were required or whatever treatment they had is completed. You go in and you follow up with the patient and say that, you know, it's resolved or not resolved, and you document here on this. The one infection that you found is documented until completion on this document. Okay, and as CMS requires, you have to talk to the patient about what they want and what their areas of interest are and what their goals are. So these also populate the plan of care. It will show the patient's personal goals on your plan of care. You can add a coordination note from here, just like the infection log. You can add a coordination note. And then we have made it easy for all of those things that you are supposed to do on your first visit, like the rights and responsibilities, engage the patient or representative in the discussion, all those things that are part of the COPs show up here. You know, now we are supposed to do a medication review every single skilled nurse visit. Medication interactions and complications are what cause patients to go back to the hospital very often. So a medication review every visit is required. So we give you an easy way to do that. They require that we talk about the disease process, safety in the home. We've got to tell them what we're going to do with them and how we're going to schedule it. And if we have, and we're supposed to contact the physician that we have admitted this patient, this is what we found, and our plan of care is to follow. Okay, so another thing that we have done different at Axxess, you know, we have always in home care, in other software, have had this massive narrative, and we have broken up the narrative just to make it easy for you to think about as the clinician, easy for the surveyor to look at your documentation and decipher what you are or not going to do for this patient, and if you've covered all your bases. So we add an intervention box, and we add a response to teaching or procedure or the intervention. It's the response to the intervention. So what I do is I number, this is what I did, physical assessment. I taught on this, I did this, I performed this, and I document that numbered. And then down here I say, the patient responded to my physical assessment. These are the abnormal things I found in my physical assessment. Number two, they were able to verbalize the key points to instruction on whatever I taught them, their disease process. And I just number the responses associated with the interventions. And then your admission summary is really just that picture of the patient that you'll see it says face-to-face addendum that supports the need for home care, for home health care, for skilled care in the home, and the abnormal findings. They're the picture of that patient in their situation and their need for home care. So that's what your narrative is, because you've taken care of all of this, all the other things up here. This is just a clean picture of the patient. And so it's a lot shorter than it was before, because you're giving very specific information in each one of these boxes. And I have started to love the way this is broken up, because it helps me organize my thoughts, and it helps the surveyor see what I have found and what I've done and how the patient responded. So I love that this is broken up, and it really helps you provide better care and helps you think about the care in an organized way. Okay, and so the other things that are required in the conditions of participation are, you know, the rehab potential that flows to the plan of care, and all of that is here, easy to document with checkoffs, and then text when necessary. And then we give you, here's the frequency. We give you a frequency description box, and that means that if you have 2 PRN visits, you want to say what those PRN visits are for. You can use this for however you want to use it to clarify your frequency. So if the physical therapist isn't going the same week that you're going, and they're not going to go until, 2 weeks later, then you're going to say that you can use this box to explain that. The PT evaluation will be effective a different week than, the week of 113, because I admitted this patient on 1/1. So love that. Okay, and so I need to explain the plan of care, and I want to show you the plan of care profile here, because it's different in the start of care, because we cue you in each section what may be needed for that section. So if you have a problem, if you have a respiratory disease, you're going to select the problem statement in that section that says alteration in respiratory status, and you'll notice that we give you this statement that is acceptable and adequate for your plan of care, but it's always editable, and you need to read through it and make sure that it's patient specific. And so if there were a reason why I didn't want to talk to them about dietary measures, then I could just take that out if it was not necessary for that patient. Okay, and then down here you have this problem of respiratory disease. So down here is when you get specific. How are you going to address that problem statement? You have this problem. How are you going to address it? Well, they have COPD, so I'm going to teach them on COPD. And then you can add or take away any of this text. And you'll see that we have asterisks, and you'll see that this is validated with a red box. This red box will not let you complete your OASIS until you correct the errors in here. So the asterisks are the areas that you absolutely need to add patient-specific information. So the asterisks have to be removed to have this intervention validated. So we're going to say that this patient, the skilled nurse is to instruct the patient caregiver in regarding self-management program for chronic obstructive pulmonary disease, emphysema, specifically. Okay, and so that's going to be my intervention, and my goal is that they demonstrate competence with self-management. So you'll see that we have more asterisks here. Who am I going to teach? Am I going to teach just the patient, just the caregiver, or both of them? And then I need to put in specific information about this patient. And then I'm going to say, I'm going to have to tell the time period that I want to complete it. And I want to say that they are going to be able to self-manage by or within 8 weeks. Sometimes it's within 1 week. It's the time period that you feel like you're going to need to teach that patient or have that patient independent. Okay, I also want you to see that in with each disease process or problem statement, you'll have medical necessity and homebound narrative. You only have to have one medical necessity statement. You only have to have one homebound narrative statement. And that means that your medical necessity is associated with the disease process that you're called in to that patient for. So we give you the opportunity to do disease-specific medical necessity statements. So we'll say that this COPD emphysema is a new diagnosis for this patient. That is why they have a need for skilled care. And so that is going to flow to your plan of care, and it also amazingly flows to your skilled nursing visit note because your medical necessity is required on each skilled visit note, and that automatically flows. It remains editable, so if your medical necessity changes, you can always change that on your note, but it will populate that and for every visit note. Same with your homebound narrative. That will flow to your visit notes. And for time's sake, I'm just going to take that asterisk out. But you would describe why it's a taxing effort to leave home. Maybe because due to patient's severe shortness of breath with ambulation of 15 feet requiring rest. I know I didn't spell that right. Okay, so that's kind of bugging me. All right, and I didn't want to use that. And so that would flow. Your homebound statement and your medical necessity statement flow everywhere that it needs to go, and specifically to your skilled visit note. Now, if you have more than one medical necessity statement, absolutely add one for each disease process or for however many reasons that the patient has of medical necessity. and homebound. So you want to clearly and fully document. So you're not limited, but you're only required to have at least one. Okay, so let's just review quickly because our time is about up. When you go into the plan of care profile, you're in the workbench and you can access it through a physician's order or through the OASIS. You're going to choose a problem statement, alteration in respiratory status, and then for that problem you're going to choose an intervention, one or multiple interventions to reach one or multiple goals. You also have the opportunity to select medical necessity and a homebound statement for that disease process. All that will flow to your plan of care that is automatically generated. Those parts that are necessary will flow to your skilled nursing note, and that is how you build your plan of care using the plan of care profile. Okay, now let's get out of that because I want to show you quickly before we end the difference in the plan of care profile from a start of care. We give you those specific problem statements that are associated with that disease. But once you have built a plan of care, remember you're creating a plan of care at start of care, and then you're updating that plan of care at different OASIS time points. And, follow up research, resumption of care. When we now have the new change in focus form that will also give you the opportunity to change your plan of care. So when you go into the plan of care from any other OASIS besides the start of care, it's going to look a little bit different, but I think that you will appreciate it. So this is the plan of care profiler, the orders for discipline and treatment. You go into there, and this is your established plan of care profile, and this is the workbench. So these are all of the interventions and problem statements with the interventions associated from your start of care. So now I'm at a research, and you know what? I have met this goal. So I'm going to resolve that goal because that is met. And you have to have at least one intervention for one goal for one intervention, but you could have multiple interventions and multiple goals for the same problem statement, but at least 1-to-1. So whenever I have met the goal and I only have one goal and one intervention left, it's going to say you have selected to resolve the last goal for this problem statement. Your active interventions associated with this goals will be removed as well. Okay, that's appropriate. That's what I want to do. So that allows you to remove that whole section for that problem because that problem is now resolved. But then if you want to add more interventions for this problem statement, you go in and use the blue text. Go down and you say, you know what, I need to teach them genitourinary precautions because she's at risk for a urinary tract infection, and I'm going to teach the patient and the caregiver, and I'm probably going to teach them about indwelling catheter care. And those things. So I'm going to make that specific to my patient, and you'll see that whenever I take away the asterisk, then the validation goes away, and so I can save that intervention. Okay, and then so you'll see that that intervention is now part of my addressing the risk for infection. Okay, so you can add and take away those interventions and goals as you meet goals for each of those. But if you have a problem statement, a new problem that you have not addressed before, you can add a whole new problem statement. So you'll add order, and let's just say that we had a problem with the need for care and advanced planning because the patient has come back and said, I really don't understand that. I might have filled it out, but I don't really understand what it's all about. So you can go in and add to teach the advanced care plan. Let's just say that's the problem. And then we're going to add a goal to address that. A goal for that intervention. Okay, and then that is how you do this and how it looks in the subsequent OASIS. And notice that you'll have a section for each discipline. Each discipline will have their own set of orders that's specific to them that will populate the plan of care. Okay, so that's the difference in the follow-up OASIS. Now let's, when you finish your OASIS, you will check for errors. And what this does is shows you where there could be some inconsistencies in your OASIS and will allow you to go and correct those. Let's see if anything shows up. Okay, so I didn't have any errors because I had been through this before, but if I did have errors, I would be able to click on that error and it would take me to that area where I needed to correct that. You'll notice that we have the PDGM case mix, HHRG, and case mix. So you'll see your LUPA threshold. Make sure that you have more than 2 visits in the first 30 days and the second 30 days, and then you'll have the opportunity to create Medicare plan of care. This is already checked for you, but if you don't want one, you uncheck it. If you do want one, or if you're creating a Medicaid plan of care, then you check accordingly. Okay? So I am finished with that OASIS. I'm happy with it, but you know what? Let me go check the scrubber, because our scrubber from Home Health Gold gives you the things that could be inconsistent or the risks involved in it. And it, just like for inconsistencies, the patient is able to feed themselves, but they need, when you said in GGO 130 that they need setup or cleanup assistance. I still stand by that. They can't load the dishwasher, carry their plate to the sink, but they can sit there at the table and put the food in their mouth. Okay, let's look down. It also now gives you the outcome potential. So, and gives you those items that this outcome potential or this question will impact. So that's your 5-star ratings and the value, those that are in the value-based purchasing states. Sorry. And then it will give you those questions that make it, put this patient at hospital readmission risk. So you want to address the hospitalization risk. Okay, so make sure you have an intervention for all those things that they're at risk for. Okay, so that is a very quick view of the OASIS and the plan of care profile. Now let me finish this so that I can show you how the plan of care looks. You'll see all the information that you entered, functional limitations, the safety, DME, caregiver status, all those things that are required by the COPs show up on this clean and nicely laid out plan of care. And then all your interventions separated by discipline and your goals. Okay? And then that goes to QA and is updated by them if necessary. Your OASIS will go through QA and could be returned to you for some repair or for some questions. Remember that QA can change your OASIS green sections and gray sections without sending it back. They will not be able to change your assessment or your blue assessment of purple plan of care. Will need your signature. And then the $ in the chart always shows you what we saw, the case mix analysis, if you have permission to see that. Okay, now I wanted to show you the skilled visit note. When you put in the intervention for a hospital risk or a fall risk, you'll see, or if you have documented that they have a DNR, it's highlighted here. That allows you to pay attention to those risks, to address those risks, and to make sure that you are cued in each time. So the infection risk is grayed out, and that's because I either resolved that intervention and they are, or they are not, I didn't find them to be at risk for infection. In another webinar, you'll go through the nurse's note, which is also very fabulous. I just wanted you to see the impact of the interventions from your OASIS on your visit note. Let me show you also. The home health aid care plan that we generated from that OASIS is here. Actually, that, yeah. So the plan of care lands, and this is from a different OASIS, and there's another webinar that will explain the nurse's note and the clinician workflow that will include all these quick reports and how to function on a day-to-day basis. I hope that I've given you some clarity on our OASIS, which is amazing and different than anyone else, and our plan of care profile. Please send in questions if you have those. About the OASIS and the plan of care profile. I would be happy to answer those. If you have no questions, please have a wonderful day and keep changing lives and doing good using the Axxess software. Have a great day. Bye-bye.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on software advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.